Hello, thank you for joining me today. Today, we're going to be talking about the new and emerging biologic agents in chronic sinusitis with nasal polyp, pathophysiology insights, and patient selection criteria. If there's any questions during the presentation, feel free to type in the questions um, into the website, and I will answer those questions at the end of the presentation. My name is Joseph Hahn. I'm currently a professor in the Department of Otolaryngology Head and Neck Surgery. I'm the chief for the Division of Rhinology and Endoscopic Sinus and Scopes Surgery, as well as the chief for the Division of Allergy at Eastern Virginia Medical School in Norfolk, Virginia. These are my disclosures. Here are our objectives. So what we're going to talk about is, some of the molecular drivers that are causing chronic sinusitis, specifically chronic sinusitis with nasal polyps. We're going to look at other comorbidities associated with nasal polyps. We're going to talk about different biologics that have been approved for the treatment of chronic sinusitis with nasal polyp and go through some of the pivotal studies. And then we're going to incorporate all this information and go through it through a patient-centric focus and talk about, how do we incorporate the biologic for our patients with chronic sinusitis nasal polyp. So with that, I'd like to start off the presentation with a pre-test polling. And so here is our first question. Nasal polyp generally reveals a pathogenic proliferation of which inflammatory cytokine drivers? So it's an interferon gamma with TNF, IL-1 and IL-6, IL-4, IL-5, IL-13, or IL-12, IL-17, and IL-33. Go ahead and submit your answers. All right, so let's go ahead and go to the next question. So which typically predominate in 50% of patients with chronic sinusitis without nasal polyp? Which of these cells are thought to also play a role with severe CRS, with type 2 CRS without nasal polyps? So eosinophils, neutrophils, CD8 cells, or Th1 cells? Go ahead and submit your answers. All right, if we can go to the next question. So a 39-year-old woman presents with nasal polyp and a history of moderate asthma. Her blood eosinophil is 302 and her total IgE is 28. Which of the biologic is most appropriate? So she has elevated eosinophils, but the total IgEs are low. Which biologic would be most appropriate? Go ahead and submit your answers. The choices are Mepolizumab, Omalizumab, Reassess, and Dupilumab. Okay, can we go to the next question? A 49-year-old man with a history of severe chronic sinusitis with nasal polyp is placed on a biologic for nasal polyp, which should be reassessed for response to the treatment per the EUFOREA guideline and the multidisciplinary consensus algorithm. So how long should a patient be on a biologic before they should be reassessed? The answers are at any time in the first 6 months, at 6 months, between 6 months and 9 months, or after anytime after 1 year. So go ahead and submit your answers. So let's go to the next question. So, 53-year-old man with severe nasal polyp presents for a follow-up visit after 12 months on biologic therapy. Prior to starting the biologic, he underwent sinus surgery twice for nasal polyps and had recurrence within 6 months after each surgery. He currently shows inadequate response to the biologic per the EUFOREA criteria and will not consider surgery. What would be the most appropriate recommendation for this patient based on the EUFOREA guideline? So a patient had surgery, had recurrence of nasal polyp, is on a biologic, is not getting better. What would you do next per the EUFOREA guideline? And so go ahead and submit your answers. All right. And I think there's one more question. Well, I think we're done. And so let's look at chronic sinusitis and specifically chronic sinusitis with nasal polyps. So when we look at the prevalence of chronic sinusitis in the US, it's pretty common. It's about 11 to 17%. Based on the CDC, there's about 29 million people in the US with chronic sinusitis. And based on the presence or absence of chronic sinus with nasal polyps, the chronic sinusitis is broken into chronic sinus with polyps and without. And we know that majority of the patients are patients without nasal polyps. But in fact, I think the evidence are starting to show that maybe the prevalence of chronic sinusitis with nasal polyp is higher than the 20 to 25% that people think that it has been. And so we'll go into that a little bit more detail. So how do you define if someone has chronic sinusitis? And the symptoms are usually the primary indicator for the absence or presence of chronic sinusitis. Specifically, we're looking for 4 symptoms that are very common in patients with chronic sinusitis, and these are nasal obstruction, nasal drainage or postnasal drainage, loss of smell or decreased sense of smell, or facial pressure. And those are the 4 most common ones. And if you look at the CT scan below, you can see that there's the CT scan on the left side is normal, while the one CT scan on the right side is abnormal because it has opacification. And there are different ways to kind of assess whether or not how severe the patient's symptoms are. And you can look at different quality of life measures. These patients, even though they have severe symptoms, they also impact their quality of life. So if people can't sleep, people can't breathe through the nose, they can't sleep. And these patients also then become fatigued, and even though they go to work, they're not able to focus at work. If you look at the nasal endoscopy below, you can see that the nasal endoscopy of the right nasal cavity is normal, while the nasal endoscopy on the left side has nasal polyps coming out of the middle meatus. So, based on what has been published in the ICAR, initially published in 2016 and updated in 2021, we say that we should be looking for 2 of the 4 major symptoms, such as drainage, congestion, facial pressure, or loss of smell. And patients with nasal polyp tend to have more likely where they lose their sense of smell, while patients without nasal polyp tend to have more facial pressure. And then not only do you want to have symptoms, you also want to have some type of objective findings. So this can be with a nasal endoscopy, looking for polyps, purulent drainage, or using a CT scan to document the level of inflammation, as we had seen earlier in the previous slides. Now, if you diagnose them with chronic sinusitis with nasal polyp, how would you treat them? And based on several publications, what is considered standard of care are using nasal steroid spray, saline irrigation. We can also use topical steroid irrigation with the saline irrigation, and even short bursts of systemic steroids. but we want to make sure we avoid the use of systemic steroids long term because it does increase the risk of several um, complications such as osteoporosis, coronary artery disease, and weight gain. If they have failed some of those traditional treatment, and when we talk about steroid irrigation, we can also do steroid delivery of topical steroids through a non-spray mechanism, such as the exhalation delivery system. So that is another mechanism in which we can provide patients with chronic sinusitis with nasal polyps. Now, if they fail those treatments, certainly sinus surgery is an option where we could remove the polyps, decrease the inflammation, and open up the sinus cavity so we can allow better delivery of the topical steroids, which is pretty much our main treatment option for our patients with nasal polyp. And those who had undergone sinus surgery, they are also eligible to get a steroid sinus implants. And these are placed into the open ethmoid sinus cavities, and mepolizumab is delivered into the sinuses over a period of 90 days or 3 months. So kind of going back, we talked about different treatment options, and this is a paper from Galen in which patients were given steroid irrigation, topical steroids, short bursts of steroids, and then they failed and they underwent sinus surgery. And if they had undergone sinus surgery, we know that a lot of these patients have recurrence of nasal polyps. And what I tell patients who have nasal polyp, I tell them it's a chronic disease. It's a disease that they have forever. So if they're diagnosed with nasal polyp at the age of 30, most likely they'll have it at the age of 70, because this is a chronic disease like hypertension. It doesn't go away. So they'll need to have some medication to better control the nasal polyps from coming back. And so surgery is not the answer. And even with surgery, a proper and appropriate surgery, the polyps will come back. And you can, so let's talk about, what is driving the polyps to come back. And so our understanding is starting to, our understanding of chronic sinusitis with nasal polyp and what is causing the problem seems to be derived initially from epithelial damage and inflammation. So in a normal, healthy sinus and nasal anatomy, you can have injury to the mucosa. The injury will then lead to repair of the gap junctions and then have a normal ciliated respiratory epithelium. But in chronic sinusitis, these patients have a chronic insult to the epithelium, which then causes inflammation. And then the inflammation prevents the epithelium from coming back to being normal. And so the respiratory epithelium can be transitional, it can be fibrotic, it can have a lot of edema. And so what is driving the inflammation? And there are 3 types of inflammatory mechanism: type 1, type 2, and type 3. In chronic sinusitis with nasal polyp, what seems to be driving the inflammation is mostly type 2 inflammation. And so when we talk about type 2, these are historically described as Th2 inflammation. So within type 2 inflammation, we see the T helper cell 2, innate lymphoid cell 2. And then the primary cytokines that we see in type 2 are IL-4, IL-5, and IL-3. Now, certainly type 1 and type 3 inflammation plays a role in chronic sinusitis, probably a little bit in chronic sinusitis with nasal polyp, but more likely in chronic sinusitis without nasal polyp. And there really isn't a distinction between type 1 and type 3 in chronic sinusitis with nasal polyp. So then that's why we say it's either a type 2 inflammation or non-type 2. And the type 1 inflammation is historically seen as a Th1 inflammation with interferon gamma being a primary cytokine. And type 3 inflammation is essentially driven by Th17 and IL-17 being the primary cytokine. Now, the mechanism of what causes inflammation is very complex, and there are different pathways. And as we mentioned earlier, it starts off with injury to the epitheliums, which then releases an alarmin such as TSLP, IL-25, and IL-33. Um, then within that epithelial damage, they can go down the allergic pathway in which IL-4 and IL-13 plays a role in terms of class switching to causing release of IgE through the IL-4 mechanism, and then the IgE can then bind to the mast cells and release inflammatory cytokine. It can also be driven by eosinophils and IL-5, and we know that eosinophils at elevated levels can cause injury to the tissue. And then we know that IL-13 draws in the eosinophils into the tissue through production of eotaxin. And IL-13 can also cause increased globular hyperplasia and mucus production, as well as fibrosis in both in asthma and in patients with chronic sinusitis with nasal polyps. And so, even though we kind of separate out the different types of inflammation seen in chronic sinusitis with and without nasal polyp, as I mentioned earlier, type 2 seems to be predominantly seen in patients with nasal polyp. But type 2 inflammation is also seen in chronic sinusitis without nasal polyp. And type 2 inflammation is seen mostly in the Western uh, patients with CRS, but in the Asian countries, it tends to be less type 2. And certainly, their chronic sinusitis can have a combination of type 1, type 2, or type 3, or type 2 and non-type 2. And so both of them seem to play a role, as shown by this diagram here. And I know this diagram is a little complex, but if you look at the eosinophil pathway, you can see it mostly on the left side of the diagram, while neutrophils can also play a role, as well as mast cells can play a role in both the eosinophilic and neutrophilic inflammation. There are different mechanisms of injury to the epithelium, which then causes different inflammatory pathways, whether it be driven mostly by eosinophils or neutrophilic inflammation. So let's kind of change gears a little bit and talk about two patients. So I'm going to present a couple of patients to you. So case one is Angela. She's a 41-year-old woman. She was diagnosed with chronic sinusitis with nasal polyp 2 years ago, underwent sinus surgery, and nasal polyps have come back. So the fact that the patients have has a recurrence of nasal polyp within a year tells us that the inflammation is likely high. And what you want to do is try to figure out what is causing the inflammation. And certainly allergy testing or a specific IgE is important. And for her allergy testing was negative. And she has an adult onset asthma. So this patient, so you want to look at comorbidities like allergies and asthma, and you can see that she's diagnosed with asthma at the later on in life. So when she had become an adult, and her blood eosinophils are elevated, her IgE, her total IgEs are within normal limits, as you saw with a specific IgE test for allergy testing, and her FEV1 is 70. So her asthma is not well controlled. So for someone like this, if if they had undergone sinus surgery already and the polyps have come back, what do we do? And someone like her, like Angela, I am very suspicious that this may be a ARD patient because the IgEs are low. She has adult onset asthma, and the amount of inflammation is high. And even for ARD, we know that it's more of a type 2 driven process because the eosinophils are elevated. Even though the IgEs are not, the eosinophils are elevated. It makes you suspicious that this is a type 2 inflammation. So let's look at another patient, Jason, 52-year-old, history of allergic rhinitis. And the patient had allergic rhinitis as a child. The patient had allergy testing and it came back positive for dust mites and cat dander. And when someone has allergic rhinitis, has chronic sinusitis with nasal polyp, and they test positive for dust mites and cat dander, I'm very suspicious of this patient having asthma. The blood eosinophil is maybe slightly elevated at 225, and the total IgEs are elevated at 150, and his FEV1 is 70. So again, the fact that his FEV1 is low makes you suspicious that even though he may not have a history of asthma, this patient most likely has asthma, and I would do further evaluation and management for that. This patient has already been on nasal steroid spray, and polyps have continued to increase in size and has not gotten better. He's done saline irrigation. Well, not everybody this patient has not had sinus surgery, and not everybody who has not had sinus surgery can tolerate saline irrigation. So I let them give it a try, and if it doesn't work, you certainly want to not have forced the issue. And for him, he has increased pressure in his ears. And so this patient, I think if they fail topical steroid spray or some type of topical steroid, and we haven't been able to optimize the treatment for that, certainly short bursts of systemic steroids is reasonable. And when you ask him how often he has the short burst of steroids, it's been 3 in a period of 2 years. So that seems like that's starting to get pretty high. And you could tell that his quality of life is miserable because he's saying, like, I want to do anything that we can to get rid of the nasal polyps. And so here we see that, the systemic steroid spray is not working. And certainly we can consider giving a systemic steroids on a long-term basis, but we can't do that because there's complications with the long-term use of topical steroids. So this patient has a type 2 inflammation as well. So let's look at some of the biologics that have been approved for nasal polyps recently. And so what are the 3 biologics that have been approved for the treatment of chronic sinusitis with nasal polyp? The first one that was approved was Dupilumab. What that does is it binds to the IL-4 receptor alpha. Binding to that receptor, IL-4 receptor alpha, it blocks IL-4 and IL-13, and that was approved in June of 2019. The next one that was approved was Omalizumab, which targets circulating IgE. And so that was approved in December of 2020. The next one that was approved was Mepolizumab, which targets circulating IL-5, and that was just recently approved in July of last year. And you can see the different dosing. So for Dupilumab, it's every 2 weeks. For Omalizumab, it could be 2 to 4 weeks, depending on the weight and the amount of total IgE. And Mepolizumab is 100 milligram every 4 weeks. So let's look at the data in more detail. So here is looking at the pivotal and primary endpoints from the pivotal study for Dupilumab. And so you see on the top is the study from Sinus 24. So in order to get a medication approved, usually you have 2 phase 3 studies. One of it was Sinus 24, and the other one was Sinus 52. And you can see on the left side is results from Sinus 24. On the left side is results from the Sinus 52. What you're looking at on the top is a change in the nasal polyp score, which was one of the primary endpoints. The other primary endpoint was nasal congestion. You could see that when the patient was given Dupilumab, you could see that there's a sharp decline until 6 months, which is when the patient Dupilumab dosing was stopped. And then when the Dupilumab was stopped, you can see that the nasal polyp score started to increase, as well as the symptoms of nasal congestion. And you can see there's a little bit of a sustained effect for about 2 months, but it does not appear to have a sustained effect overall. But when these patients were given dupilumab further than 6 months, as seen in Science 52, you could see not only did the nasal polyp continue to decrease, but you also see that the nasal congestion also decreases as well and continues to decrease. And you can see that the primary endpoint was measured for both nasal polyp and nasal congestion was measured at 6 months. And if you look at the sinus 52, you can see these patients were either given Q24 or Q2 after 6 months. And you can see that in the sinus 52, after 6 months, after week 24, there really isn't a big separation between the CRS with nasal polyp patients that were given dupilumab Q2 or Q4. It looks like the 95% confidence interval seems to overlap, especially for the nasal congestion. So not only are symptoms and the polyp size important, what's really important for patient is whether or not they have to keep using systemic steroids or have to undergo sinus surgery. And so what the study did was capture incidents in which a patient was given systemic steroids or surgery. And what you see here is that over time that the placebo group started to increase in the number for the use of systemic steroids and undergo sinus surgery. And in fact, it's about 3 to 1. So placebo group was 3 times more likely to undergo surgery or be given systemic steroids compared to those who were received dupilumab. So those are the results that patients are interested in seeing. And so what we can tell patients is that if you get dupilumab for your nasal polyp, it does decrease the rate of having to do sinus surgery or using systemic steroids. So we know that dupilumab is effective in patients with CRS with nasal polyp. Is it safe? And so that's what we're showing here in this table. So we're looking at the most common adverse effect associated in the dupilumab study, the Science 24 and 52. And if you look at the most common adverse effect is nasopharyngitis and headaches. And so, and then you can see that the injection site is present for both the placebo and the treatment group. But nasopharyngitis seems to be the most common adverse effect. And I'm kind of wondering, really, is it an adverse effect of the drug, or is it really a progression of the disease? And it's kind of hard to tell, right? So let's look at the next biologic, Omalizumab, in the treatment of nasal polyps. And so we see here in the Polyp 1 and Polyp 2 study that the patients had a decrease in the nasal obstruction, similar to what we saw in the dupilumab for nasal polyps. So, and the primary endpoint was measured at 6 months at week 24. And you could see that there was a difference in about change of 1 for the nasal congestion. And you can see there is an improvement in the nasal polyp score of about 1 as well. And so, so if we look at the so if we look at nasal congestion score, we could see that there's also improvement in the nasal congestion as well, and it's a little under 1 at week 24 for both Polyp 1 and Polyp 2. So so what we see here from the 2 slides is Omalizumab is effective in our patients with nasal polyps. It improves the nasal polyp score as well as nasal congestion, as we saw with dupilumab. The question is, what about the safety record? And you can see that that the top 2 most common adverse effect was asthma, exacerbation, nasopharyngitis. So again, having asthma exacerbation is not necessarily an adverse effect of the omalizumab, but more a progression of the disease. And you can see that the rate of acute exacerbation and nasopharyngitis seems to be higher in the placebo placebo group than the Omalizumab group. So let's look at the Mepolizumab data. So if we look at the Mepolizumab data, this is a little bit different. So what we're seeing here is on the top half of the graph, we're seeing improvement either in nasal polyp score or nasal congestion, while the bottom group is the placebo group. And you can see that that the top group has higher percentage of patients with a change in the nasal polyp score. And you could also see that the treatment group also has a higher percentage of improvement in their nasal congestion. Um, and the primary endpoint for this study was measured at week 52, while the other ones were measured at week 24. And similar to the Dupilumab study, the Mepolizumab measured those who had undergone surgery. So in the Dupilumab study, what they did was they measured whether or not they had the need to do surgery. Here in the Mepolizumab, these are patients who actually underwent sinus surgery. And so what you see here at the week 24, which was when the primary endpoints were measured, you could see that there was a decrease in the need for sinus surgery for those who received Mepolizumab versus those who received the placebo. So from this graph, we can show that Mepolizumab also decreases the need for doing sinus surgery for nasal polyps. So those two studies also show that Mepolizumab is effective in treating our patients with nasal polyp. So let's look at the adverse effect. So again, the leading adverse effect is nasopharyngitis, and you can see that it's similar between the placebo group and the treatment group. And so overall, the Dupilumab, Omalizumab, and Mepolizumab seems to be effective for nasal polyp, and both three biologic appears to be safe in our patients with nasal polyps. Now, there are other studies that are currently ongoing looking at the treatment for nasal polyps. The other two biologics that we know of is one is Benralizumab. Benralizumab just finished the Austral study, which is one of the phase 3 study. The other phase 3 study is Orchid, which is still ongoing. And so hopefully that will be done soon. The other one is Tezepelumab, which targets TSLP. Benralizumab actually targets IL-5 receptor alpha, which is different than Mepolizumab. Mepolizumab targets the circulating IL-5, while Benralizumab targets IL-5 receptor alpha. And we see in terms of dosing, both of them are start off at Q4 weeks, but Benralizumab after the second month then jumps to Q8 weeks. So they get it every 2 months after the second month. So that'll be interesting to see what the data shows from those two biologics for nasal polyps. So if we look at, one of the questions that comes up is, how do we, make a comparison? And you really can't, because the study populations between the groups are very different. And so we can't really do a direct treatment comparison between the three biologics. But there is one measure that's been consistently across the used, one tool that has been used across the three biologic, and that's the SNOT-22. SNOT-22 is a quality of life measure and is a subjective patient-reported outcome. And what's nice about that is that the MCID has been calculated. So the minimum amount of change that a patient needs to see to notice a difference in terms of their symptoms has been calculated, and that is 8.9. So if we look at SNOT-22, And the way you want to evaluate SNOT-22 is see how much drop there is from the baseline. So when you're looking at the MCID, you want to see, how much has the SNOT-22 change from baseline. So if we look at Dupilumab at week 24 to 52, which is when they were being measured, you could see that with the Dupilumab, there was a drop of about 30 points. So that's 3 times that of the MCID. If you look at Omalizumab, the data that we have is at week 24, and you can see at week 24, Omalizumab has a drop of SNOT-22 about 21 to 25. So that's twice that of the MCID, maybe 2.5 times that of the MCID. And if we look at Mepolizumab, measured at week 52, you can see that the drop from the baseline is about 30. And so that is about 3 times that of the MCID. So these patients definitely notice a difference in terms of their symptoms when given these biologics for their nasal polyps. So then how do we decide when to start implementing or using the biologic in our patients? And so there have been several papers that have come out that have kind of tried to give some guidance based on the publications and expert opinion. So the first one is this paper, which is a multidisciplinary approach to a stepwise management of chronic sinusitis with nasal polyp. So this is the second half of the figure. And so, these are patients, if they're diagnosed with chronic sinusitis with nasal polyp, both have subjective and objective symptoms. They failed optimal treatment of topical steroid delivery, whether it be spray, the exhalation delivery system, or maybe in some patients, maybe a steroid irrigation. If they fail that, the expert felt that majority of patient would benefit from sinus surgery. So these are patients who've never had sinus surgery. If they fail topical steroids, some of the patients, majority of the patient would benefit from doing sinus surgery. And from an economic standpoint, from a healthcare system, it makes sense that that should be the first approach. And after they do sinus surgery, you want to give them postoperative medical treatment, which mostly includes topical steroid. Now, there are patients who've never had sinus surgery that may not be candidates for surgery. So these are patients who have poor lung function, and these are patients who may have steroid-dependent asthma and have poor lung function and may not be a good candidate for general anesthesia. Those patients should not undergo sinus surgery. Or there are some patients that may not want surgery through a shared decision-making process. And those patients certainly would maybe benefit from the use of a biologic. Now, for those who have undergone sinus surgery and have given postoperative medical management, as we mentioned earlier, many of these patients will have polyps come back despite appropriate sinus surgery and appropriate topical steroid or other medical management. And these are patients who often have comorbid asthma. And so I think that's why it makes sense to have a multidisciplinary approach. It should be a discussion that, maybe the ENT, the otolaryngologist, the pulmonologist, and the allergist all need to kind of talk together about these very difficult to treat patients on how to kind of how to approach this patient and how to manage them. And in that decision-making process, the patient also needs to be involved. And I think it's very important that we need to incorporate the patient's wishes and desires of what treatment options that we can provide. The great news is we have lots of treatment options for these patients with recalcitrant nasal polyps. So I think it's great that we have all these treatment options that we have available, whether it be biologic, revision sinus surgery, desensitizations in patients with aspirin triad or ARD, steroid sinus implant, or even short bursts of systemic steroids. And after the use of a biologic, you want to reassess them at 6 months. And the reason why we picked 6 months was because that's when the primary endpoints for most of the biologic studies for nasal polyps were assessed. And so initially in the 2019 EUFOREA paper, we had kind of come up with a list of criterias on who should get a biologic. And then in 2021, last year, we redefined that. And the way we defined it is similar to what we see in asthma. So there are patients with uncontrolled chronic sinusitis with nasal polyp, or patients with severe chronic sinusitis with nasal polyp. And so here are the definitions. And sometimes the definitions can intertwine. So there could be patients with severe nasal polyps that are uncontrolled. And so similar, those or uncontrolled patients can also be severe. So they can certainly overlap. But these are the two patients that we think would be a good candidate for a biologic. And so here are some, and we talked about shared decision-making process earlier. And so here is a website. It's currently on the American Rhinologic Society as well as the American College of Allergy and Asthma Immunology website. And here, this is a tool, a paper tool that, or electronic tool that patients can use to try to help understand, the different treatment options that we talked about. So when we talked about in that multidisciplinary approach, we talked about there's so many different options, how do we educate the patient? So this paper tool or electron tool, what it does is just really educates the patient. It tells them, do you mind getting injections every 2 or 4 weeks? Do you mind doing surgery? Do you have a preference for one treatment options or another? And so then based on that, the patients can kind of understand the different treatment options, use that tool and give it to the physicians so the physicians can get a better understanding of what the patient desires are, and then you can have a better discussion. So once you place them on a biologic, you want to wait about 6 months to predict whether or not it works or not. And again, of these patients with recalcitrant nasal polyp, these are patients where the polyps come back. Often they have comorbid asthma. So EUFOREA is very similar to the stepwise approach to the nasal polyp, in that it should be a multidisciplinary approach where the otolaryngologist and the pulmonologist and the allergist kind of get together and discuss how do we best treat our patients. And so, and again, you want to reassess them in about 6 months. So going back to our presentation, our cases, let's go back to Angela. So, so this was a 41-year-old female, history of no allergies, but adult onset asthma. What additional tests will we get asked for? So we check for blood eosinophils, total IgE, and specific IgE. I mean, one of the tests, and as I mentioned earlier, this patient is very suspicious for aspirin triad. So one of the things that I would like to check is on urine LTE4. And urine LTE4 is a systemic way to measure for the amount of glucotrienes. So that may be one test that I would consider getting, but it's not readily available. We do measure it in our lab, but commercially it's not really readily available. So for this patient, would I do sinus surgery, revision sinus surgery? And it would really depend on the CT scan and what the CT scan shows. So if it shows that all the sinuses have not been opened up, so like the sphenoid sinus, or oftentimes we see that the frontal sinuses have not been opened up. I mean, if the frontal sinuses have not been opened up, but the sphenoid sinuses have not been opened up, or if there's ethmoid cells that have not been completely dissected out, certainly I would consider doing sinus surgery on those patients. But if the sinus surgery has already been all opened up, would you do sinus surgery again? And it really depends on the patient. This is where I talk to the patient and tell the patient, sinus surgery is not a cure for your nasal polyp. A lot of these patients think that, sinus surgery is a cure, and I tell them that it's not. And that if you do sinus surgery, the polyps will come back. And so, certainly I would talk to them about a biologic. And if they had a complete sinus surgery, I think a biologic is a very reasonable option. And for this patient, the patient has elevated IgE, has a type 2 pattern of inflammation. So both Dupilumab and Mepolizumab seems to be a reasonable option. The IgE was not elevated, so Omalizumab I would not necessarily consider for this patient. And so back to Angela, I would say, how do you feel? Here are the different treatment options. And I would look at the patient and kind of personalize not only the medical treatment, but also the surgical treatment as well. So let's go to Jason. So we talked about Jason. So this is a patient with allergy. He's had it as for a long time. He probably has asthma that he probably doesn't know, and I would definitely have him consider getting a pulmonary function test and having him see the doctor managing his asthma, and so it could be the otolaryngologist, allergist, or pulmonologist, whoever is comfortable managing the asthma, because his FEV1 was below that of his predicted. So he probably didn't even know he had asthma. One other test that I may consider is pheno testing, and to see if his exhaled nitrous oxide is elevated. And to patients, the pulmonary function test and pheno testing are objective measures. And for them, they really do kind of look at that number. And, you may tell them, how do you feel? How often do you cough? But to patients, when I show them a pheno testing or a pulmonary function test, and I said, this is what your testing shows, for them, that means a lot, just like a CT scan. So when someone has sinusitis and I show them the CT scan, the amount of opacification associated with that, that means a lot to the patient. So those are additional tests that I may consider for this patient. This patient has not had sinus surgery, and so would I recommend doing sinus surgery after his asthma is better controlled? Yes, I would say that this patient probably is a good candidate for sinus surgery, but certainly I would also talk about shared decision-making process, because we have patients in different parts of their life or career or circumstances where surgery may not be an option, where they may not need to take they may not be able to take the time off to do the surgery. So I certainly would consider doing shared decision-making process and talk about whether or not surgery is a viable option. And for this patient, is a biologic recommended? I would say probably I would agree with most of the experts in that paper that surgery is probably an option. But if the patient doesn't want to have surgery, certainly a biologic is an option. Which one? I would say, it seems that all three works. This patient has elevated IgE. The eosinophils aren't too elevated, so Mepolizumab maybe, and the Dupilumab, it seems like he has a type 2 pattern, so that may be an option for this patient. So as we mentioned earlier, in the EUFOREA guideline, if a patient is a candidate for biologic, you should reassess them at 6 months and see how they do. And if they are improving and they're doing well, I would say consider continuing monitoring them. If they've not gotten better, I would certainly talk to them about doing surgery or considering another biologic. And so I think the 6 months seems to be the right number, because you don't want to start them on a biologic and not give enough time for the biologic to work. And so we've seen that, where patients have some initial improvement. A few months later, they're not where they want to be, and they say they want to do surgery or a biologic. And I tell them, give it a little bit more time. Let the topical steroids work with the biologic. And, and these biologics are all meant to be as an add-on therapy. And so they should be on a biologic with the topical steroids to make sure they have a good response. And then after 6 months, if they had a good response, you want to reassess them at 12 months. And then if they are continuing to do well, you want to continue them on a biologic. The question that next comes up is, how long to keep them on? And I think the answer is we don't know. I mean, no one knows for sure. But for now, if they've been on a biologic, they have a good response, I would just keep them on it. And because the polyps won't go away. And so once you stop the biologic, it's very likely that the polyps will come back. If they don't have a good response after 12 months and they feel like they have persistent symptoms, certainly doing sinus surgery or considering another biologic is an option. And so, as we mentioned earlier, there are no head-to-head clinical trials that have been published yet. There is currently a clinical trial ongoing at this time that's comparing Dupilumab to Omalizumab, but we'll have to wait and see what those results are. But to kind of summarize, Dupilumab targets IL-4 receptor alpha, which targets IL-4 and IL-13, and it seems to work very well in type 2 driven inflammation. Omalizumab targets IgE and appears to be very effective in patients with elevated IgE, regardless of their atopic status. And Mepolizumab targets IL-5, and IL-5 and eosinophils go hand in hand. And I suspect that IL-5 does more than just affect the eosinophils. It probably also affects the mast cells as well. And so, in summary, I think it really is important for us to understand the cause of chronic sinusitis, especially nasal polyps, because of the introduction of biologics. So the biologic is a new treatment options that we have, new class of treatment options that we have that are very effective in patients with very severe nasal polyps. And so by understanding what's causing the nasal polyp, we can better understand, why the biologic works and which biologics will work for certain CRS with nasal polyp patients. And we know that understanding that there are lots of treatment options that are available, and so and that's very fortunate because in the past, we were relegated to either systemic steroids or surgery. Now we have lots of different treatment options that we can provide to our patient. So I think it's a great time to for our patients with really recalcitrant nasal polyps, because now we have really good treatment options that we can use to help our patients. So with that, I like to go to our post-test polling. So those questions that we had asked earlier, we're going to ask them again to you. So nasal polyps generally reveal a pathogenic proliferation of which inflammatory cytokines? So which of the cytokines are driving the nasal polyps? So interferon gamma or tumor necrosis factor, IL-1 or IL-6, IL-4, IL-5, IL-13, or IL-12, IL-13, IL-12, IL-17, and IL-33. So please pick your answers and submit your answers. Okay, great. And let's go to our next question. So, which typically predominate in 50% of patients with CRS without nasal polyp? Which of these cells are thought also to play a role in the patients with type 2 chronic sinusitis with nasal polyp? So if we're looking at the different cells that are involved in chronic sinusitis with polyp and without, which of the inflammatory cells are associated with that? Is it eosinophils, neutrophils, CD8 cells, or T helper cells? And so, so go ahead and submit your answers. So again, which of the inflammatory cells are commonly seen in patients without polyp as well as with nasal polyps? So go ahead and submit your answers. Okay, let's go to the next question. So, a 39-year-old woman presents with nasal polyp and a history of moderate asthma. Her eosinophil is elevated at 302. Her total IgE is low at 25. Which biologic appears to be the most appropriate? Mepolizumab, Omalizumab, Resolizumab, or Tezepelumab? So this patient has eosinophilic um, asthma and nasal polyps. And so which of the different biologics below seems to be appropriate for this patient? So this patient has elevated eosinophils and the total IgE is within normal limits. So which biologic would you consider? And this patient has both nasal polyp and asthma. Okay, let's go to the next question. So, 49-year-old male with severe nasal polyps is placed on a biologic for the nasal polyp. When should he be when should he be reassessed for response to the treatment per the EUFOREA guideline and the multidisciplinary approach? So, is it um, at at any time within the first 6 months, at 6 months, between 6 months to 9 months, or anytime after 1 year? So, after a patient is started on the biologic, at which time should you reassess the patient to see if they have a response to the biologic? And those are your answers, choices, and please submit your answers. Okay, let's go to I believe this would be the last question. So, 53-year-old man with severe nasal polyp presents after a follow-up after 12 months on biologic therapies. Prior to starting the biologic, he had undergone sinus surgery twice and had nasal polyp recurrence within 6 months after each time. And so the patient currently has inadequate response of the biologic per the EUFOREA criteria and would not consider surgery. So, what would be the next appropriate recommendation based on the EUFOREA guideline? So, the patient um, basically has severe nasal polyps, had undergone two sinus surgery, has been on biologic for 12 months, and is not getting better. So, based on the EUFOREA guideline, what would you consider? Would you switch to another biologic? Consider the biologic for another 3 months? Consider fluticasone spray? Or stop the biologic and go to a medical treatment again? So, those are your answers, choices. And go ahead and submit your answer and submit the question. Okay, you can go to the next slide. Okay, so this is time for Q&A, and if there are any questions, you can submit them. Um, I don't currently see any questions. So that's great. So I'm glad that I hope that this session has been very helpful in helping you understand what causes nasal polyps, why biologic is effective in our patients with nasal polyp, and based on some of the evidence, the recent evidence-based publications, that they've been able to give you some guidance on how to treat our patients with nasal polyps. So with that, I'd like to thank you. And for additional resources and information related to chronic sinusitis with nasal polyp, please visit this website, integrityce.com/NP resources. You will now be redirected to the evaluation to claim your CME, or you can go to this website to claim your CME, integrityce.com/CRS with nasal polyp eval-5. So I appreciate you